This is Chapter 38, Critical Care of Patients with Neurologic Emergencies. TIAs are often warning signs of an acute ischemic stroke. A TIA is a temporary neurologic dysfunction resulting from a brief interruption in cerebral blood flow. Symptoms can be easily ignored and usually resolve before the patient gets to the emergency department. The vision may become blurred. They may have double vision. There may be vision loss in one or both eyes or tunnel vision. For mobility, there may be weakness, which includes facial drooping, arm or leg drift, and the hand grasps, and ataxia, which is a lack of muscle control and coordination. For our sensory deficits, there may be numbness in the face, hand, arm, or leg. And for our speech, there may be aphasia, which is problems with speech and language, or dysarthria, which is slurred speech. Our causes include carotid stenosis, which is hardening and narrowing of the artery, decreasing blood flow to the brain, along with atherosclerotic plaque buildup and atrial fibrillation. For our assessment tools, we will use the NIH stroke scale and the ABCD2 tool. Risk factors also include the patient being greater than or equal to 60, a blood pressure greater than or equal to 140/90, clinical TIA symptoms, the duration of the symptoms. The longer the symptoms last, the greater the risk of stroke, diabetes history. The ABCD2 tool is used to determine the risk of having a stroke in the days or weeks after a TIA. For treatment, treat the cause if known. There may be surgery to remove atherosclerotic plaque buildup in a carotid artery. There may be a carotid angioplasty with a stent to increase perfusion to the brain. We have antiplatelet drugs such as aspirin, clopidogrel, which is Plavix, to prevent strokes. We may have management of high blood pressure. We want to control diabetes, keep that glucose between 100 and 180. And we also want to promote lifestyle changes such as smoking cessation, eating healthy, increasing mobility, and our physical activity. A stroke is caused by an interruption of blood flow to any part of the brain, resulting in cell death. It is the leading cause of death, disability, dementia, and depression in the world. A stroke is a medical emergency and should be treated immediately to reduce or prevent permanent disability. Time is brain function here. So whenever you have a stroke, we are blocking our normal blood flow and our oxygen that is going to our brain cells. The longer our brain is deprived of that oxygen, the more cell death that we are going to see, and the more deficits we're going to see as a result of that cell death. Our strokes are going to be divided into two different types. We have an acute ischemic stroke and hemorrhagic strokes, and we will discuss these more on the following slides. First, we have our acute ischemic stroke. So these strokes are going to be caused by the occlusion of a cerebral or carotid artery by a thrombus or an embolus. So a thrombotic stroke is going to be whenever we have a clot that is already in one of these arteries and it is gradually building and gradually occluding blood flow to the brain. An embolic stroke is going to be whenever we have a condition such as AFib, a heart valve disease, or endocarditis, where a clot is built somewhere else in the body, such as in the chambers of the heart, and then the patient will, we call it throwing a clot. The patient will throw this clot and it will travel through the bloodstream and it will actually go up into their brain where it will get lodged in those arteries and it will occlude blood flow there. So the occlusion can break into smaller pieces and then travel to smaller vessels where they're absorbed, and this is why symptoms have a sudden onset and then can rapidly improve. Hemorrhage usually results from severe or sustained hypertension. The elevated blood pressure causes changes to the arterial wall, which causes it to rupture. The bleeding causes edema, inflammation, and displacement, which puts the pressure on the brain tissue. Cocaine use is one example of an increase in blood pressure that can lead to a hemorrhagic stroke. A subarachnoid hemorrhage is more common, and it is caused by an aneurysm or an arteriovenous malformation. An aneurysm is an abnormal ballooning along an artery, and it may be congenital. It may develop in a weakened side of the arterial wall, or it may occur after trauma. It causes bleeding into the subarachnoid space, ventricles, or intracerebral tissue, and the patient will complain of a severe headache. You may hear, "This is the worst headache of my life. It was so sudden, came out of nowhere," with nausea, vomiting, photophobia, a stiff neck, or other symptoms. And then for an arteriovenous malformation, these can be embryonic malformations of tangled or twisted vessels, and they can cause the eventual possible rupture. For our characteristics, these are going to have an abrupt onset. The patient is lethargic or stuporous, severe neurological deficits, bloody cerebrospinal fluid, and permanent neurologic deficits can occur. To look at your conditions here, we have genetic conditions. 1 in 3 U.S. adults have had at least one of these conditions, and our stroke risk also increases with substance abuse, especially alcohol and cocaine, and the use of oral contraception. So you guys will see if anybody takes a oral birth control, that it'll say on the package, if you are taking this medicine, do not smoke. And the reason is because it increases your risk for blood clots and it increases your risk for strokes. The priority for stroke patients is transportation to the nearest stroke center for prompt treatment. Remember, time is brain tissue here. Other relevant information can be taken later. One important part of the history is any recent bleeding events and anticoagulant use. Important questions to ask are symptom onset. What was the patient doing when the stroke began? Were symptoms sudden or gradual? Did symptoms worsen after onset or begin to improve? The patient's medical history, current medications, and social history. Assess the patient within 10 minutes of arrival to the emergency department and complete the NIHSS, and that stands for National Institute of Health Stroke Scale, and that's going to help determine the eligibility for an IV fibrinolytic. You guys can review table 38.2. It is on page 948, and that is going to show you guys what we ask and what we do whenever we do this NIHSS. Now, I do want to touch back on this. Most hospitals will require that their nurses, especially critical care nurses, are certified in being able to do this stroke scale. Usually it's an annual certification. But what this is going to do is it's going to have you ask the patient questions to determine their level of consciousness. It's going to have you have them point things out on a picture to see, are they comprehending what they're seeing? It's going to check their neurologic status. And then we're going to do some things that check their motor function as well. The most common symptoms of a stroke include confusion or trouble speaking or understanding others, hence why we point to these pictures for the patients whenever we're doing this stroke scale and have them tell us what they see. Sudden numbness or weakness of the face, arm or leg, dizziness, trouble walking, loss in balance or coordination, and trouble seeing in one or both eyes. These are all things that we can test with the stroke scale. Dysfunction can vary depending on the hemisphere of the brain that is affected. So if it is a right-sided CVA, if we're going to have paralysis, it is going to cross over that plane in the body, and we are going to see left-sided paralysis. So whatever side of the brain is affected, we are going to see the results physically on the opposite side of the body. So for a right-sided CVA, we're more likely to see disorientation to time and place, personality changes with impulsivity, and poor judgment. For the left-sided CVAs, remember, if it is on your left side and you have paralysis, then it is going to affect the right side of your body that paralysis is. This is the Center for Speech, Language, Math, and Analytic Thinking. So what you're going to see here is aphasia, agraphia, reading problems, alexia, and dyslexia. So these are important to know, and the reason is because depending on the symptoms is going to give you key ideas as to where we're having this issue in our brain. For our psychosocial assessment, assess the patient's reaction to illness and changes in body image and independence with ADLs. Screen for depression, assess for access to resources and the need for social services. And then emotionally, an uncontrollable emotional state, especially if the right side or frontal lobe is involved, we're going to have emotional lability. And the patient will often laugh and then cry for no reason. Lab tests are not definitive to diagnose a stroke. However, elevated H&H is associated with major strokes. The patient's glucose and A1C are used to determine if the patient has diabetes and if it is controlled. I will say this, not because it's on your test or anything, not because it's necessarily a standard, more so because I found out the hard way. So a extremely critically elevated blood sugar or a critically low blood sugar, either one, can actually mimic the signs of a stroke. So if you have a patient, especially those who are diabetic, and they start to show these symptoms while you are obviously activating your stroke protocol, please check a blood sugar because sometimes it really can just be that. We're also going to check a PT, INR, and APTT, and those are going to be used to establish a baseline before giving any fibrinolytic or anticoagulation therapy. For imaging, a CT is going to be used to determine what type of stroke the patient is having and whether it is hemorrhagic or ischemic. You will see a CT. Every patient who comes in and has a stroke is going to have a CT scan. That's usually a part of every hospital's policy. First thing they're going to do is get a CT scan. And then they have an MRA. This is the magnetic resonance angiography. This detects early changes in the brain and it is going to confirm blood flow. When we analyze our cues and prioritize our hypotheses, let's go ahead and look at some of the diagnoses we might start to see. So we're going to see inadequate perfusion to the brain due to interruption of arterial blood flow and a possible increase in intracranial pressure. We may see decreased mobility and possible need for assistance to perform ADLs due to impaired cognition. We may see aphasia and or dysarthria due to decreased circulation in the brain or facial muscle weakness. We may also see sensory perception deficits due to altered neurologic reception and transmission. Treatment for ischemic strokes include fibrinolytic therapy and endovascular interventions. For fibrinolytic therapy, this is going to be our clot-busting drug. This is going to dissolve the cranial artery occlusion to restore blood flow and prevent cerebral infarction. IV alteplase is the only drug approved currently. The FDA advises TPA alteplase is given within 3 hours of the stroke onset. So for this reason, you will see that not everybody is a candidate to receive TPA. TPA is wonderful for helping prevent those long-term effects of strokes, and it also decreases our mortality rate in the long run, but not everybody can get it as soon as they come in. Some people have started showing stroke signs and symptoms a few hours beforehand. Some people may have shown signs and symptoms the day before, and those candidates are not going to be able to receive this. Other people who may not be able to receive this type of therapy include people who are over the age of 80, people with a previous history of strokes, or a patient who is showing any signs of bleeding, and that is the risk we're taking here. If someone comes in and we are suspecting they are having a hemorrhagic stroke, we are not going to give them TPA because TPA is going to increase the risk for bleeding. For that reason, we are also going to make sure that we are monitoring the patient after administration. We want to look for signs of intracerebral hemorrhage and bleeding. If the patient has extremely high blood pressure, they may not get TPA because with that high blood pressure, we don't want to increase their risk for bleeding. On top of that, that way, if for some reason we have an artery wall rupture, if we have a blood vessel rupture due to that high blood pressure, we're not increasing the risk for this patient hemorrhaging. Whenever we do our TPA bolus calculation, we are going to take 0.9 milligrams per kilogram, and that is going to be our total dose. Whatever 10% of this total dose is what we are going to initially bolus into the patient. For our endovascular interventions, these are procedures to improve perfusion. Intra-arterial thrombolysis with drug therapy can be given within 6 hours of onset. An embolectomy, this is a surgical removal of a blood clot, and a carotid stent placement can be examples of these treatments. For the treatment of hemorrhagic strokes, we have procedures to stop further bleeding. These patients are at risk for increased intracranial pressure. We are going to monitor frequently for the first 72 hours after stroke onset, and we are going to perform frequent neurological checks. The first sign of an increased intracranial pressure is the decrease in the level of consciousness, and box 38.5 details the symptoms of increased intracranial pressure. For preventing and managing increased intracranial pressure, we're going to elevate the head of the bed to improve perfusion pressure. Think about whenever you're congested, you don't want to lay flat on your back because it increases the pressure in your head, so you sit up a little bit. We're going to provide oxygen and an O2 sat that's less than 95% to prevent hypoxia. We are going to maintain the head in a neutral and midline position to promote venous drainage from the brain. That would include whenever we are moving the patient, we're log rolling them, we're not really moving their head around a lot. We are going to avoid clustering nursing care. We want to maintain a quiet and dim environment. We want to make sure that we are looking at the airway. We're preventing coughing and the need for suctioning. If suctioning is required, we want to hyperoxygenate the patient before and afterwards. For our mobility and ADLs, patients should remain in PO until a speech language pathologist, that is your speech therapy, determines that the patient can tolerate liquids and foods. A lot of our stroke patients are at risk for aspiration, so we want that licensed professional to come in and clear them and say, hey, even if it's just a sip of water, yes, they can have this, or no, they cannot. Their ability to swallow is impaired. Impaired mobility can lead to the development of a venous thromboembolus. That is going to be a VTE. A lot of times we'll see these in the legs, so we encourage SCD use to prevent a DVT. For communication, we have dysarthria, which is the difficulty forming and speaking words. We have dysphagia, which is defective speech. We have aphasia, which is the loss of speech. And then we have expressive aphasia. This is where the patient understands what you're saying, but they're not able to form their own understandable words. We also have, we have expressive aphasia, we have receptive aphasia. This is when the patient is unable to comprehend the spoken or written word. They can speak, but it might not make sense. And then we have global aphasia. This is a mixture of expressive and receptive aphasia. Our interventions for communicating: present one idea at a time, use simple commands, speak slowly, avoid yes or no questions, use alternate forms of communication such as boards or flashcards, and don't rush the patient when they are trying to speak. This is already frustrating for them. They don't need to feel rushed. Facilities must demonstrate consistent performance of these 8 core measures to be a certified stroke center. For our patient and family education, a lot of facilities will just have a booklet for these on top of nursing education. But the education we are going to provide is we are going to educate the family and patient on prescribed medications, on preventing another stroke and controlling hypertension, a consult with PT for education on mobility aids, ambulation, and transfer skills, safety precautions, communication skills, when to seek emergency care, the fast pneumatic, face drooping, arm weakness, speech and language difficulty, and when it's time to call 911. View our expected outcomes to see if our patient has met these. Something I want to focus on here, especially the last 2, think about how you can communicate with someone who has aphasia. Incorporate those nonverbal cues. Present one idea at a time, use one-step commands, and don't rush the patient when speaking. And to make sure that the patient has adequate nutrition and they are avoiding aspiration, think about how you can ensure that the patient is not actually aspirating. One example would be to listen to the lung sounds. Make sure they have clear lung sounds so we know they're not aspirating food into their lungs. What's in the body whenever we have a traumatic brain injury? Whenever we have these injuries, there is damage to the brain from an external mechanical force. When I say that, I mean we're having a brain injury not from dementia, not from Alzheimer's, anything of the sort. This is something from the outside that is going to damage us. It's not something that we develop from the inside. Force can be direct or indirect. Think if you directly hit your head, something directly hits you on top of the head, that would be a direct force. Say you get in a car accident and your seatbelt catches you, your head swings forward, and your brain is just knocked around inside your cranium, that can cause a secondary force. That's an indirect force. So the brain responds to these forces by movement within the rigid cranial vault. The brain can be contused, which means it can be bruised, or it can even be lacerated, which is where we have those tears, as it moves over the inner surface of the cranium. That inner surface is irregularly shaped, it's hard, and it's sharp. Brain tissue is fragile and easily injured, so the brain can be injured by an initial force, such as a concussion. Think you're playing football, hit your head on the field, boom, you have a concussion. It can also be caused by a secondary injury from mechanical pressure or cerebral edema. That goes to say, so boom, you hit your head, you have a concussion, that's your primary injury. Well, down the road, due to complications of that, you develop what's called post-concussion syndrome, and this occurs as a result from the initial concussion. So this would be a secondary injury. Our head injury often occurs as a result of a blow or a jolt to the head, or as a result of penetration of the head by a foreign object such as a bullet. Brain damage from trauma most frequently involves the frontal or temporal lobes. For our etiology, we're looking at falls, a motor vehicle accident, ETOH and substance abuse, violence, and sports-related injuries. Damage to brain tissue depends on the location, degree, and mechanism of injury. Normal functioning is impaired, resulting in cognitive and physical short-term or long-term problems. The force can be direct or indirect injury to the brain. The direct force is forced by a production of a blow to the head, and an indirect is a force applied to another part of the body with a rebound effect on the brain. So think, what if you had a patient who had a traumatic brain injury? They're being discharged from the hospital, and because of where they have this brain injury, they have personality and behavioral changes. How are you going to help the family and family members cope with this? One of the things that I would recommend is to teach the family to develop a home routine that provides structure, repetition, and constancy for this patient. Let's talk about the different types of TBIs. So primary brain injury occurs at the time of the injury. A focal brain injury is confined to a specific area of the brain, and it causes localized damage that can often be detected with a CT scan or an MRI. Diffuse injuries are characterized by damage throughout many areas of the brain. An open head injury occurs when there is a skull fracture or when the skull is pierced by penetrating objects. The integrity of the brain and the dura is violated, and exposure to outside contaminants occurs. A closed head injury is the result of a blunt trauma, and here the integrity of the skull is not violated. A TBI is further defined as mild, moderate, or severe. Generally, the determination of severity of a TBI is the result of a Glasgow Coma Scale score immediately following the patient's resuscitation. For our open injuries, these damage soft brain tissues, vessels, and cranial nerves. For our closed injuries, this is where we are going to have damage to the brain tissue, but no opening through the skull or the dura. Usually this occurs when the head accelerates and then decelerates, or collides with another object such as a dashboard or wall, and it is actually the more serious of the two injuries. A secondary brain injury. The most common secondary injury from a mild TBI is going to be the post-concussion syndrome. Here the client is going to complain of headaches, impaired cognition, and dizziness, continuing to occur for weeks to months after the initial brain injury. An acceleration injury is caused by an external force contacting the head, suddenly placing the head in motion. So think about a football player is just standing stationary on the field, and another player comes and tackles him out of nowhere. He went from his head being stationary to all of a sudden accelerating, and now it's going to be knocked around in his cranial cavity. And then for a deceleration injury, this occurs when the moving head is suddenly stopped or hits a stationary object. Think that same football player, okay? So we have a football player, he's running, he gets tackled, and boom, his head hits the ground. That forward motion of his head coming down towards the ground, and then it suddenly stops as soon as his head hits the ground. Even though he's wearing a helmet, his brain is going to get knocked around inside his cranium cavity. There are different types of force involved in a traumatic brain injury. It's very important to teach patients about wearing helmets to help on motorcycles, bikes, and football. And the forces can be great on the brain, even causing the cerebrum to rotate around the brainstem, which is going to cause damage to brain tissue and hemorrhages. Especially, this is going to affect the basal nuclei and the hypothalamus. An arterial bleed in the space between the dura and the inner skull can cause a brain hematoma, which is a collection of blood, or a clot. This is called an epidural hematoma. This may occur as a part of the primary injury and begin at the moment of impact. Epidural hematomas are typically caused by temporal bone fractures. The temporal bone houses the middle meningeal artery, and this is where the bleeding comes from. As a result, the artery bleed can cause rapid pressure to the brain. Signs and symptoms include a loss of consciousness at the time of injury, then the patient will be lucid. During the lucid time, the body is compensating for the expanding hematoma, and when the body can no longer compensate, the intracranial pressure rises, and there is going to be another deterioration of consciousness, fixed dilated pupils, or paralysis of the extremities. A loss of consciousness is a neurosurgical emergency. If this happens, you need to notify the provider immediately or notify the rapid response team. Because we're having this swelling, our treatment is going to include decreasing intracranial pressure by making a burr hole in the skull to remove the clot and control bleeding, or a craniotomy may be required. A subdural hematoma is going to be a collection of blood between the dura and the brain, and it is going to develop over 24 to 48 hours. Symptoms are changes in level of consciousness, pupillary changes, and hemiparesis. An immediate craniotomy is done, and mortality rate is high because of the associated brain damage. Subdural hematomas have the highest mortality rate because they often go unrecognized until the patient presents with severe neurologic compromise. This is why accurate assessments are vital. Typical signs and symptoms include worsening headaches, paresis, acute confusion, and seizures. In some cases, the patients may experience a decreased level of consciousness up to and including a coma. Assessment. We are going to ask the patient, do they have a history of seizures? Has there been a change in level of consciousness? Did the patient become unconscious? For our key features for a mild traumatic brain injury, some of these include appearing dazed or stunned, feeling mentally foggy, drowsiness, or irritability. You guys can take a further look at these on page 961 in box 38.7. For our physical findings, table 38.3 on page 957 has a great box for these things. You guys will notice that the worse the injury, the more there is an impact on the body's ability to regulate its own vital signs. For example, there's Cushing's triad. This is a very late sign of intracranial pressure. Here you will see severe hypertension, a widened pulse pressure, and bradycardia. We have Horner's syndrome. This is a disruptive nerve pathway on one side from the brain to the face and the eye. Symptoms of this will include a smaller pupil, drooping eyelid, and little or no sweating on the affected side. A fever is going to be an indicator of a poor prognosis for a brain injury. Assess for increased intracranial pressure, hypotension, hypoxemia, and hypercarbia. For our spinal precautions, this is a big one. So anyone who has a suspected brain injury or spinal cord injury will usually come in on a spine board and a cervical collar. We try to remove that spine board as soon as possible once they have the clearance, and we will remove the cervical collar once we also get clearance from a provider. That rigid cervical collar is applied and left in place to maintain the cervical spine or your C-spine. One of the things we want to make sure we do is monitoring the skin underneath and change it if it gets soiled. Early indicators of a change in level of consciousness include behavioral changes and disorientation, which are often subtle in nature. Report any of these signs and symptoms immediately to the primary healthcare provider or a rapid response team. For critical rescue, check the pupils of the TBI patients for size and reaction to light, particularly if the patient is unable to follow directions. This is going to be done to assess changes in the level of consciousness. Document any changes in pupil size, shape, and reactivity, and notify the rapid response team or primary healthcare provider immediately because these changes could indicate an increase in intracranial pressure. The primary healthcare provider is going to make the decision that it is okay to move the spine. Up until this point, we will be moving the spine very rigidly. We do not want to cause too much movement, so if we have to turn the patient, we're going to log roll them. Patients with any level of TBI usually have varying degrees of psychosocial changes that may persist for a year or for a lifetime, depending on the severity of the injury and the person's response. Emotional lability and/or personal changes manifesting with temper outbursts, depression, risk-taking, and denial of disability can also occur. As with any critically injured patient, priority is given to maintaining a patent airway, breathing, and circulation. Cerebral perfusion is maintained by taking vital signs every 1 to 2 hours and reporting any cardiac dysrhythmias, hypo or hypertension to the provider. The provider should have parameters in the standing orders to let you know what to do in any of these cases. A fever is an indicator of poor prognosis in a TBI. With or without fever, they may use therapeutic hypothermia to reduce the work of the brain, thereby preventing a secondary injury. Therapeutic hypothermia is rapidly cooling the patient's temperature, which is going to slow the metabolism and help save brain function. The body will be cooled to 89.6 to 93.2 degrees Fahrenheit for 24 to 48 hours. Rewarming is done very slowly, and an experienced nurse will definitely help you do this or assist with this. The rewarming can cause fluid and electrolyte shifts, which will cause cardiac dysrhythmias and changes in blood pressure and intracranial pressure. For these reasons, of course, we are going to be doing cardiac monitoring, we are going to monitor vital signs, and we're going to monitor those lab values. We want to monitor peripheral oxygen saturation continuously in moderate to severe traumatic brain injury patients. Patients with severe TBIs do often die. As the physiologic deterioration begins, keep in mind that the patient may be a potential organ donor. So before brain death is declared, we are going to go through our facility's policy to contact the local organ procurement organization. Most facilities have a protocol in place for this organ donation. For example, do not ask the patient's family member anything about organ donation. Okay, that is not your place. We will contact the facility who does that, and their representative will come and they will speak to the family about our solutions in the situation. But do not put yourself or the family in that position. For our prescriptions, mannitol is an osmotic diuretic, and it is often used to treat cerebral edema by pulling water out of the extracellular space of the edematous brain tissue. It is most effective when it is given in boluses rather than as a continuous infusion. Furosemide is a loop diuretic, and it is often used as an adjunctive therapy to reduce the incidence of rebound from mannitol. Opioids such as fentanyl may be used with ventilated patients to decrease pain and control restlessness. Rehab is done to maintain functional ability, item and face recognition, and this rehab requires positivity and encouragement and lots of repetition. Cognitive rehab assists patients to be able to function independently. They will use sensory stimulation to help the patient learn to respond appropriately to their environment. Some patients with TBI experience seizure activity as a result of primary or secondary brain injury. Be sure to initiate seizure precautions according to your agency's policy and procedure. Even if your patient does not have a history of seizures, you will initiate these seizure precautions because it is a possibility with that increased intracranial pressure. And always introduce themselves, make instructions short and to the point, reorient the patient to the date and the time, give them rest periods, and make sure that the patient has a sleep schedule. Being on a routine is very proactive in healing and is often underthought. Brain tumors. Brain tumors can arise anywhere within the brain structures. We have primary tumors, which are located within the central nervous system, and secondary tumors that result from metastasis in other areas of the body. Tumors can lead to cerebral edema, brain tissue inflammation, increased intracranial pressure, focal neurologic deficits, obstruction of cerebrospinal fluid flow, and pituitary dysfunction. We are going to discuss two classifications of tumors: The first is going to be whether it is benign, which is non-cancerous, malignant, which is cancerous, or metastatic, which is where it has spread. It is cancerous and it has spread. We will discuss these a little bit more in Module 5 as well, but for now, you just need to know those 3 differences in that classification. The second classification is going to be based on location. So this is where they are in the brain in relation to the in relation to the tentorium. Try saying that 3 times fast. So that is going to be the fold of the dura mater. So supratentorial is going to be tumors located within the cerebral hemisphere. With these tumors, we may see paralysis, seizures, memory loss, cognitive impairment, language impairment, and vision problems. And then we have infratentorial. These are located along the brainstem structures and the cerebellum. With these tumors, we may see ataxia, autonomic nervous system, vomiting, drooling, hearing loss, vision impairment, and increased intracranial pressure. A few more things that we are going to see in our assessment. Common symptoms include headaches, nausea and vomiting, seizures, impaired sensory perception, loss of balance or dizziness, weakness or paralysis, difficulty thinking, speaking, or articulating words, and changes in cognition, mentation, or personality. The goal of treatment is to shrink the tumor and improve the patient's survival time. Radiation therapy can be used alone or combined with chemotherapy, which may be one drug or a combined regimen. Analgesics will be used such as Tylenol and codeine. Decadron will be used to reduce edema. Dilantin will be used for seizures. Even if the patient does not have a history, they are at risk. And proton pump inhibitors or histamine blockers like Protonix or Zantac are used to decrease gastric acid. Procedures, we have SRS. This is a stereotactic radiosurgery. This is an alternative to traditional surgery. So one type of SRS is gamma knife, which uses a single high dose of radiation to focus multiple beams of gamma rays on the tumor. Gamma rays are produced by cobalt-60 isotope and destroys intracranial lesions without damaging the healthy tissues around the tumor. Advantages include that it is non-invasive, it is a lower risk than a craniotomy, there is a decreased cost and morbidity, a shortened length of stay, and rapid recovery time. The disadvantage is that it requires an uncomfortable rigid head frame. So pick and choose your advantages over your disadvantages for this. A craniotomy is more often used. So for pre-op care, talk with the patient about anxiety and reassure the patient and the family about the procedure. That does not mean instill any false hope, everything's going to be okay. No, we don't do that. We just want to make sure that they are well informed and they are in capable hands. The patient needs to be NPO for 8 hours, no alcohol, tobacco, blood thinners, or NSAIDs at least 5 days to a week before surgery. Hyponatremia is a post-op complication which can result in seizures. Therefore, it is important to monitor sodium levels. For our post-op care, the focus is to monitor to detect changes in status and prevent or minimize complications, especially increased cranial pressure. We are going to monitor the dressing frequently for drainage. Drug therapy for post-op includes anti-epileptic drugs, proton pump inhibitors, histamine blockers due to the risk of stress ulcers, corticosteroids to decrease cerebral edema, acetaminophen for fever or pain, and prophylactic antibiotics. Post-op care for a supratentorial surgery. This is for the cerebral hemisphere. Elevate the head of the bed 30 degrees or as tolerated to promote venous drainage. Avoid extreme hip or neck flexion. And we need to position the patient's head midline in a neutral position to prevent increased intracranial pressure. They can turn side to side or remain supine to prevent pressure ulcers and pneumonia. For infratentorial, the brainstem surgery, the patient needs to remain flat and side-lying, alternating sides every 2 hours because we want to minimize pressure to the neck area incision and the internal tumor excision site from a higher cerebral structure. We are going to monitor neurological and vital signs every 15 to 30 minutes for the first 4 to 6 hours and then every hour. We want to report any new neurodeficits to the provider. The patient will be NPO for the first 24 hours due to edema around the medulla and lower cranial nerves, which may cause vomiting and aspiration. It is normal to have periorbital edema and possibly black eyes. Patients may have fluid restrictions if there is pituitary involvement. And honestly, the patient is usually on a vent after surgery for the first 24 to 48 hours. Other things that we want to be sure of post-op after we have had any kind of management, we want to maintain a reasonable quality of life. Why are we doing this? What are our expected outcomes? Is everybody educated in this situation? We want to maintain a safe environment and monitor for seizures. Remember, once again, just because a patient has never had a seizure, if they have a brain tumor, they are at an increased risk. Go ahead and take a moment to read your question, review your answer choices. You can pause the video here to give yourself some time to answer. The answer to this question is C. The airway must be protected. Elevating the head of the bed prevents swallowing concerns and allows for an open airway. Go ahead and take a moment to review the question here. Select your answer choices. Please note that this is a select all that apply. You can pause your video here so you have some time to answer. The answer to this is going to be B, C, and E. Clients who are experiencing a left hemisphere stroke display an inability to discriminate words and letters, intellectual impairment, and deficits in the right visual field. Remember, if you have a stroke on the left side of your brain, you are going to have right-sided deficits on your body. Disorientation, constant smiling, and neglect of the left visual field are manifestations of a right hemisphere stroke. Go ahead and take a moment to review each of these. There is a 3A and 3B. You can pause your video here while you take your time to answer your question. For 3A, before the client is given any liquids, food, or medications, they're going to be screened for the ability to swallow. Remember, our speech language pathologist usually does this. Depending on the severity of our symptoms, a nurse may do a swallow evaluation and then consult the speech language pathologist if there's an issue. For 3B, clients must meet strict eligibility criteria for fibrinolytic therapy. This includes giving the drug ideally within 3 hours after the first stroke symptoms for most clients. So go ahead and take a moment to review this question, review your answer choices. You can pause your video here while you are debating your answer. The most reasonable answer here is going to be B. And the reason the other answers are incorrect is because restraints should not be applied until all alternate methods have been attempted. Sitting with a client for 2 hours is impractical for the nurse, and placing a call light in the client's right hand would not be effective because he has deficits in his right visual field and may actually just have an entire right field neglect. Take a moment to read your question here, review your answer choices. You can pause your video here so you have a moment to answer. The answer to this question is B. So feeding clients falls within the scope of practice of an assistant personnel member. When you're thinking of these people, think of your CNAs or your patient care techs. It is not appropriate to delegate to a hospital volunteer. The LPN can be delegated other types of client care rather than this. And a student nurse doing their first clinical care experience should not be delegated under these circumstances. Take a moment to read the question and review your answer choices. You can pause your video here while you answer. So the answer to this question is D. Asymmetric pupils, loss of light reaction, or unilateral or bilateral dilated pupils are treated as herniation of the brain from increased intracranial pressure until proven differently. Pupils that are fixed and dilated are a poor prognostic sign. Clients with this problem are sometimes referred to as having blown pupils. Other findings are not anticipated. Take a moment to review this question, review your answer choices, and you can pause your video here while you take your time to answer. The answer to this question is C. The first sign of increased intracranial pressure is a declining or changing level of consciousness. Therefore, the nurse must assess the client immediately when this symptom is present. Go ahead and take a moment to review your question and your answer choices. This is a select all that apply. You can pause your video here so you have time to answer the question. The answer to this question is A, B, and E. The right cerebral hemisphere is more involved with visual and spatial awareness and proprioception. This is the sense of the body's position. A person who has a stroke involving the right cerebral hemisphere is often unaware of any deficits and may be disoriented to time and place. Personality changes include impulsivity, which is poor impulse control, and poor judgment. The left cerebral hemisphere is the center for language, mathematics skills, and analytic thinking. Therefore, a left hemisphere stroke may result in aphasia, alexia, agraphia, or acalcula. So that is the conclusion of Chapter 38. If you have any questions or if there are any concepts that you cannot clear up with your own research, please do not hesitate to reach out to your course instructor. We are always here to help you. That's what we're here for. You do have resources. You can go online, use your ATI, use your Evolve resources, but they are out there. We want to see you succeed, and I hope that this PowerPoint was helpful for you.